Good morning, everyone. My name is Rebekah Gardner from the New England QIN-QIO, and I'll be moderating today's webinar. I've gone ahead and placed everyone on mute, and we will give you instructions for asking questions at the end of the presentation. So thank you for joining us for today's webinar, Using Data to Improve Care Transitions and Reduce Readmissions. This call will be recorded for training purposes, and I'll provide you with information on how to access that at the end of the webinar. As I mentioned, the phone lines are on mute, and we will be taking questions at the end of the presentation, and I will give you the instructions then how to ask a question. We would like to encourage you to post questions using the chat feature at the bottom right corner of your screen. Please make sure to send your messages to all participants so that we can keep up with the incoming questions. At this time, I'll pass things over to Maureen to get us started.
Morgan, and welcome everyone. Thanks everyone, and welcome. As Morgan said, I am Maureen Leary, and we are so happy to have you all here today to unveil our enhanced readmission reports. It's particularly exciting to be partnering with Sandra Parker and the HIIN on what I hope will be the first of many collaborations to share information and educational opportunities. We are sincere in our hope that this presentation elicits questions and conversations. These reports are created with you in mind to help drive quality improvement and reduce readmissions. There will be room at the end for questions, and as Morgan said, please feel free to enter any questions or comments into the chat feature of this presentation. I'm going to hand it off to Sandy for a quick minute, and I'll talk to you soon.
Hi, this is Sandra Parker from the Maine Hospital. Maine Hospital Association. Good morning and welcome. I'm delighted to have the turnout today. Over 2/3 of Maine's hospitals are registered for this webinar. It is an honor for MHA to work with the QIN-QIO on this important topic, and it's also an honor for us to be part of the CMS Hospital Improvement Innovation Network through our partnership with the American Hospital Association's Health Research and Education Trust. We're delighted that some of our CMS deliverables overlap with those of the New England QIN-QIO, providing us opportunities to collaborate more closely together. As you may have guessed, reducing avoidable readmissions to the hospital is one such area of overlap, and everybody's working on it. We're hoping to not be part of the problem here, but to give you more tools that will be helpful to you as you work to reduce those at your hospital. Every hospital recently received their new hospital-specific readmission report from the QIN-QIO, and these updated reports provide wonderful information. And part of today's program will explain how to use and understand these reports, particularly relative to using care transitions to reduce readmissions. If you don't have the report from your hospital in front of you, please nudge your neighbor and see if you can get it, because it would be important information to have. And if you can't find it for some reason, please put a note in the chat box, and the QIN-QIO staff can send one directly to you. So, thank you. I don't have anything else to add at this point, so I'm going to turn it back over to you, Maureen.
Thank you, Sandy. As Sandy said, people who registered for the call in advance, we tried to send out the reports to folks. So if you have those handy, they're great to follow along with. And if you don't, as Sandy said, just write it in the chat, your facility name and your contact information, and we'll get those to you. We're going to hold off until after the presentation to get those to you so that we can focus on what we're doing here. While the reports are helpful to go along with during this presentation, they aren't necessary, and you'll be able to get the full gist of what we're talking about. So you can just go along. And about the reports, these reports are created for each facility at our center in Rhode Island by our Manager of Analytics, Blake Morphis, who you'll be hearing from in just a moment. Each quarter, after Blake posts them, I send them to quality leaders and the CEO of each facility. I want to say right now, though, that this contact list is admittedly a work in progress, somewhat outdated, and we're working on correcting that. So if you haven't received them in the past, there are several ways to rectify this. you can contact me directly. All of our contact information will be placed at the end of this presentation if you don't already have it. You can indicate your name and email in chat, but the best way to update this list is so that we have a complete picture of who should be receiving these reports, is at the end of this presentation we'll have an evaluation survey, and there's room in there to indicate who are the quality leaders in your facility that should be receiving this report. And as I said, these reports are sent quarterly, but this data does have about a 6-month lag time. So the reports that we'll be reviewing and that you have just been sent will be covering quarter 14 from 2016. The reports that we're presenting today are enhanced reports. You've received readmission reports from us before, but these will look different than the ones you've received. We've listened to the providers, quality leaders, and facilities as we've gone around and presented the reports and listened to you about what would both be helpful in content and how things are displayed, and Blake has been working really hard on making those adjustments. I personally really love these enhancements, and the facilities and people that we've shared them with so far have all expressed positive feedback. This doesn't mean, however, that there isn't room for improvement or we have sort of closed the door on them. If there's something that you'd like to see or see differently, we are still open to that. These reports are created for you so that you can take action in order to improve your quality projects and care transitions. I know I referred to the evaluation survey before, and there will be a place for you to indicate any suggestions or questions on that evaluation survey, so please feel free to take advantage of that. We are also in the process of creating a share file where all of our contacts can actually go to a secure area in a designated link to receive these reports. We're still working out the details on this, and we'll get back to you on it, but so you can see why having an accurate and up-to-date contact list is important. And again, there'll be a place on the evaluation survey to indicate who should be receiving this. And I guess last but not least, which isn't indicated here, is why are we doing this reports in this presentation? We create them. These reports, particularly with these most current enhancements, are designed to drive quality improvement and care transitions. I think you'll see that they can give you an at-a-glance snapshot into trends and opportunities and help you quickly identify areas of opportunities within your facility to focus on. And again, I want to mention that the presentation will be available on our website, and we'll provide you with the link. So if there's a question or something you want to refer back to, you can jot it down, but it will be held so that either you can go back and review or others in your facility can review. I couldn't be happier to have you all here to gain insight into these reports with the help of these two fine speakers. Dr. Gardner is a well-respected published author in the care transitions world. I urge you to take advantage of her insight and expertise during this call to ask questions about not only these reports, but quality improvement projects, care transitions that you're working on or thinking of working on. Blake Morphis, as I mentioned earlier, is our manager of analytics here at the QIO. He has worked extremely hard at putting this report and its enhancements together, and he knows them inside and out. So again, I urge you to take advantage of his expertise and ask plenty of questions while we have him here. This webinar was really put together with two purposes in mind. Clearly, we want to be able to inform you and educate you on the reports, but we also want to elicit questions and conversations. The reports are really only as good as how they're being used, and this is a great opportunity to ask questions on how to make these reports actionable. So I'm going to urge you again, put out a plea. I hope you're getting the theme. Ask questions, put them into chat. Please feel free to share what's going on in your facility, any challenges or things you'd like to highlight. There will also be time at the end of this presentation for Q&A, but we're happy to monitor our chat feature as well. And with that, I'm going to turn it over to Dr. Gardner.
24 hours pretty much is fine. So we'll arrive Thursday, and we'll meet Thursday.
Good morning, everybody. Hey, Rebekah, before you get started, we're hearing somebody's private conversation, So I'm going to go ahead and remute the phone line. So Rebekah, once you hear the automated person, if you'll then press #6 again so that we can get it started. I'll have to unmute and then remute, so bear with me for just a minute.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press #6.
Okay, everyone. Thank you, Maureen.
Perfect.
Okay, everyone. Thank you, Maureen. Today we're going to be talking about the New England QIN-QIO hospital reports and how they can inform the quality improvement work that's already going on in your own hospital and maybe even inspire you to take on a few different types of projects. You can see on the slide in front of you a typical QI implementation cycle. And these reports will help you in several of the QI steps in the cycle, which are shown in the darker blue ovals. As Maureen mentioned, we've recently enhanced the reports based on the feedback we've been hearing from all of you. We've all read the research, we've all seen the penalties. Certainly at the hospital I work at, we've seen plenty of penalties on this. But these reports help you take a closer look at what's going on in your own institution and community. They complement the data that you're already generating in-house to your own dashboard. And what they allow you to do is build a more complete picture by providing needed data in a usable format. In order to get the full story, though, you'll also need to ask your frontline staff and your patients and their families about their experiences, as well as talking to your community partners. Those last two topics are topics for another day. We love talking about those. We think that they're incredibly valuable, and the QIN-QIO and the HIN are also here to help you with those. But today we'll be focusing on data reports. Before we dive into the QIN-QIO hospital report, we're going to touch briefly on two other reports that you're probably familiar with, so you can see how all the information you're getting in these different reports is complementary, but maybe a little bit different. First, we'll start with the PEPPER report. These were initially developed back in 2002 to help with hospital compliance, basically how to avoid improper Medicare payments due to billing errors, and to help hospitals identify areas of potential concern where the hospital was kind of an outlier compared to their peers. But people quickly realized that there was also an opportunity here to use the data for quality improvement. Like the QIN-QIO reports, the data comes out quarterly. However, they run in the CMS fiscal year, not the calendar year like the QIO reports. So, for example, quarter 1, fiscal year 2017, would actually correlate with quarter 4, calendar year 2016, which is how the QIO reports are done. There's also a data lag, but it's not always clear what the lag time is. It's likely longer than the 4 to 5 month lag in the QIO reports, so the quarters are not going to sync up exactly as the claims are constantly being adjusted by Medicare. Also importantly, primary site diagnoses are not included in PEPPER. They are included in the QIO report. There's actually a separate PEPPER report specifically for inpatient psych facilities, and those data are released annually. But that's kept separate from the main PEPPER hospital report. Similarly, and important for me, the critical access hospital stays are not included in the main hospital PEPPER report. There's a separate critical access hospital report from PEPPER, and those data are also released annually and not quarterly. If folks have questions about the PEPPER report at the end, we're happy to do our best to answer those as well. There's also a HIN hospital report, which I know you are all familiar with. These measures are also hospital-wide, and they do a separate, a subset of Medicare fee-for-service measures. So there's an all-payer, and then a subset of those is the Medicare fee-for-service. And these do include psych and really all conditions except childbirth. They don't generally include readmissions to other hospitals because this is data that's coming from you. It's self-reported data. And I'd like to turn it over to Sandra and see if she wanted to add something else about the report and the CMS goal that's listed at the bottom.
Hi, this is Sandra, and I think you you've covered it nicely, and all of the main hospitals, which is just about everybody, is subject to the CMS goal of reducing unavoidable admissions by at least 12%, which is a pretty lofty goal, so this webinar is timely indeed. Thank you.
Thanks, Sandra. Okay, we're going to move on now to the main event. Blake is going to walk us through the QIN-QIO hospital report section by section, and I'll be chiming in occasionally to discuss how you might use the information in a particular section.
Okay, thank you, Dr. Gardner. So, as Dr. Gardner mentioned, we're going to go through each section of our newly enhanced hospital reports, and as we get to the end of each section, she will provide additional insight on how you can use each section of this report. Some highlights from our report include being able to assess trends over time for readmissions, ED, and observation utilization. We also provide diagnosis-specific readmission data, number of days to readmission, demographics, and readmissions relating to discharge disposition. Before we get into the report, I'd like to bring up a few important items about our data. We are looking at solely Medicare fee-for-service claims data. A readmission can be at any facility nationwide. We are now including psychiatric patients. So patients that are discharged from a psych unit are included, and patients that are readmitted to a psychiatric unit or facility are counted as readmissions. Our data is not risk-adjusted. It is solely based on Medicare fee-for-service claims, and our reports are available quarterly. In Section 1 of the hospital report, we provide your facility's all-cause 30-day readmission percentage. All charts in our hospital report cover 3 years, or 12 quarters. Each quarter is based on a calendar quarter. For example, Quarter 1, 2016 covers the time period from January to March of 2016. The blue line, which you will see on charts throughout our report, represents your facility's all-cause 30-day readmission percentage. The green line, which, like the blue line you will see throughout the report, represents the all-cause 30-day readmission percentage for the state. Down at the bottom of the chart is a table that provides you additional information on what's being plotted for each quarter. Here you will find the percentages for your facility and the state, as well as the numerator, readmissions, and the denominator, live discharges for your facility.
So for the readmission data, this can help in seeing the big picture in your hospital and how you compare to the rest of the state. These are the measures you're most used to seeing. They're in all the reports you're getting, and it's just very helpful to see that all in one place. One nice thing about these data is that the data trend over time. You can see what your progress is and if the individual interventions you're doing are actually having an impact on the overall readmission rate.
Also in Section 1 of our hospital report is a chart on the number of days until readmission. The number of days until readmission chart provides how many readmissions occurred on a given number of days post-discharge. So an example we see here, this facility had 40 patients readmitted 1 day after discharge, 37 patients were readmitted 2 days after discharge, and 25 patients were readmitted on day 3 after discharge. I'd like to point out that for this chart, we are using a 1-year time period as noted here. We also provide the total number of readmissions that occurred during that 1-year time period. And over to the right, we also provide some quick information that tells you how many patients were readmitted within 7 days and how many patients were readmitted within 14 days.
Thanks, Blake. This figure, I love this figure. It really helps you identify when most of your readmitted patients are coming back to the hospital after discharge. So you can see if it's in the first few days, maybe you're getting a huge surge 3 days within 3 days of discharge, or maybe it's in the first 3 weeks. That's a very different type of event that would cause folks to come back in the first 3 days versus the first 3 weeks. So this information can really help you generate hypotheses of what the potential drivers for these readmissions might be. And then you can design interventions that target the highest risk times for your particular patient. We'd like to point out this figure and really all the subsequent figures for hospitals that are smaller in scale. There may be a little bit more variation in the numbers from quarter to quarter when you see the report, because you're going to have smaller numbers overall. And so small changes in the number of folks coming back in a particular month can really are really magnified when you're charting data. So we just want to put that make that note of caution. I know that folks who work in smaller hospitals are used to seeing swings in data occasionally when their numbers jump around a bit, and that's certainly true in these reports as well. By grouping the data into quarters and years, we take a little bit of that variation out, but it's certainly something to still keep in mind.
Okay, so in Section 2, we provide condition-specific readmissions. For condition-specific readmissions, we base them on the Agency for Healthcare Research and Quality Clinical Classification Software, or CCS. The CCS is simply a system of grouping diagnosis codes into a category. One of the important aspects to keep in mind with a readmission measure is what diagnosis a readmission gets assigned to. We refer to this as the index admission diagnosis. The index admission is the first admission, and we're looking to see if the patient was readmitted for any diagnosis within 30 days. So let's take a look at an example. Let's say a patient leaves the hospital with a diagnosis of acute MI. And then sometime within 30 days, the patient gets pneumonia and returns to the hospital. In this scenario, when looking at a readmission measure, we would assign this readmission to acute MI. Since the patient originally left the hospital with an acute MI and returns to the hospital within 30 days, in this scenario, we refer to an AMI as the index admission diagnosis and pneumonia as the readmission diagnosis. Going back to our hospital report, the example we have here shows the trend of AMI 30-day readmissions over a 3-year time period. Like before, the blue line represents the facility's percentage of all-cause readmissions for AMI. And the green line represents the state's percentage of all-cause readmissions for AMI. Underneath the chart is information on each quarter's specific readmission percentage, number of readmissions, and live discharges. Remember, as I said before, these data are based on an index admission diagnosis. Therefore, the readmissions and live discharges are specific to the diagnosis category. So, for example, in quarter 1, 14, this facility had 20 discharges for AMI, and 7 were readmitted.
So this section of the report takes a closer look at the traditional diagnoses covered by the Hospital Readmission Reduction Program, along with a few others like diabetes and sepsis that are also known to be important conditions for readmission. So if you're doing condition-specific programs, let's say like a post-discharge heart failure clinic, here's where you can track the impact of that type of intervention. You can see if your hospital is an outlier for a specific condition compared to the rest of the state, and it might prompt you to look more closely at opportunities to improve the care processes in place for that particular condition. So if you have a heart failure clinic or you're specifically doing follow-up phone calls for folks discharged with a specific condition, you might not expect that to change your overall readmission rate. But here's where you would look to see if it's impacting the actual condition readmission rate for which you're targeting those patients. This is an important place to look at that. And if you can see, for example, that your hospital has way more readmissions for sepsis than other hospitals, that might prompt how you're taking care of folks with sepsis or how those folks are going out into the community after being treated for sepsis in your hospital. So this is a great place to generate hypotheses.
Okay, so moving on to Section 3, we provide your facility's top 10 index and readmission diagnosis categories. So we break out top 10 readmissions in 2 ways. One, as we just discussed, is based on the index admission diagnosis category. That is, what the patient left the hospital with on the initial admission. The other is by readmission diagnosis category, which provides the top 10 diagnosis categories when readmitted. So here we have the table for the top 10 index admission diagnosis categories for quarter 4, 2016. On the left, we have provided a description of the diagnosis category. Next, we have the total number of readmissions for the Index Admission Diagnosis Category. After that, we provide the total readmissions. Note, these are the total readmissions for this facility during the most recent quarter, which in this example is quarter 4, 2016. The last column is the percent of total readmissions. So we can see in our example that out of 217 readmissions, 20 patients, or about 9%, originally left our facility with a diagnosis of pneumonia. The second table in this section is for the readmission diagnosis categories. You can see the table is set up just the same as the index admission table. Just as a reminder, this table represents the top 10 reasons why a patient was readmitted.
So in this section, you can continue to look at specific diagnoses and some of those that may not be a part of the hospital readmissions reduction program. Here's where you can begin to look more carefully at the contribution of behavioral health and substance use disorders, and you can see if the top 10 diagnoses actually make up a substantial proportion of all your readmitted patients. Just add up those percentages on the far right, and you can see if, sometimes people look at their top 10 diagnoses and it turns out it's not even a third of all the readmissions or why folks come in. So they may not want to target one of those specific conditions or even the top 10. They may want to not take a condition-specific approach. A lot of hospitals started out targeting specific conditions because of the nature of the hospital readmission reduction program, but it may not be the most effective strategy at this point for a lot of hospitals.
In Section 4 of our hospital report, we provide the top 10 index admission categories with associated readmission categories. So let's talk about what exactly that means. In this section, we take your facility's top 10 index admission categories and we link them up with what the readmission diagnosis categories were. So let's take a look at an example. Just a few slides back, we looked at this facility's top 10 index admission diagnosis categories. At the top of the list was pneumonia, which had 20 readmissions. In other words, 20 patients left this facility with pneumonia and were readmitted within 30 days. In the second column, you can see that we list out the readmission diagnosis categories for 20 patients. And in our example, we can see only 6 were readmitted because of the same diagnosis category. 3 were readmitted due to respiratory failure, and 2 due to congestive heart failure, and so forth. In the last 3 columns on the right, we provide you a little more information on where the patient was readmitted. Did the patient return to your facility, or did they seek care at another facility within your state? Or lastly, did they seek care at a facility in another state?
This section helps you explore a particular diagnosis more fully. You'll often see that most people are not returning with the same diagnosis they were admitted for in the first place, the first time they were admitted. This section and the previous one are a great place to notice patterns and to pull charts for a closer look at what some of the underlying issues might be. These data can also help you target patients to interview upon readmission to get more information. Most hospitals can't interview every single patient who comes back within 30 days. So these data and the charts that you've seen in the last few slides can help you figure out who you might want to put your resources toward to get more information. These are really great data to help you ask questions and to think about how care is delivered in particular scenarios. So we have an example here. If you notice that you have a lot of your pneumonia patients coming back with urinary tract infections, this is a great time to look at how catheters are used in the hospital. That's just one example.
Okay, so moving on to Section 5, Demographics and Chronic Conditions, and Readmission 2. In this section of the report, we provide a table that summarizes demographic information. Please note at the top of the table is information on the time period. For this table, we look at a 1-year time period. As we move forward each quarter, this time period will roll by 1 quarter. So it starts by displaying the summary of all your facility's readmissions during that 1-year time period. For our example facility, we can see they had 804 readmissions out of 4,431 live discharges, which is 18.1%. Over the past year, this facility has had a lower readmission percentage than the state, which is at 19.7%. We also provide readmission information for age categories under 65, between 65 and 84, and 85 plus. We provide readmission information broken down by race, which can be used to help identify any disparate populations. These categories are based on the categories specified for Medicare Part A claims. We also provide readmission information for patients with chronic conditions. For chronic conditions, we look at all the diagnosis codes submitted on the claim. The patient may have multiple chronic conditions, and in that scenario, that patient will be counted more than once in this table. It is important to keep this in mind because the conditions for COPD, diabetes, and heart failure will not match the condition-specific readmissions we discussed earlier in Section 2 because they were based on the principal diagnosis code. And at the very end of this table is a summary table on where a patient was readmitted to. For this table, we provide you with two time periods, the most recent quarter and the past year. We provide the total readmissions, and we provide how many readmissions for patients that were readmitted at your facility, how many readmissions were at other facilities in your state, and lastly, how many patients were readmitted to facilities that are located out of state.
This section is chock full of useful information. You can see what the highest risk age groups are in your hospital. In southern New England overall, it's actually younger Medicare beneficiaries, those under 65 that are readmitted more than the oldest old, those over 85. In northern New England, it tends to be the oldest old that are readmitted more frequently. But let's see if that's true in your hospital as well. If so, you might think about different types of interventions. It's going to be a very different transition out of the hospital for a 45-year-old on disability who has Medicare compared to a 90-year-old leaving the hospital with Medicare. You might think about different types of interventions for those different populations. Now, if different racial or ethnic populations are admitted at different rates, it's an opportunity to think about why that is. Maybe you're seeing higher rates among Latino patients, or better interpreter services needed at discharge, perhaps. You can also see which comorbidities are associated with higher rates. Let's say your numbers are really high among folks with dementia. This might spark you to say, we need to do a better job getting patients' families and caregivers in at the time of discharge to make sure that the right person is getting the information when they need it. Lastly, you can figure out where your patients are going where they're readmitted. Maybe it's not your hospital. As Danielle mentioned in the chat, for folks in Maine during the summer who have a lot of seasonal residents and tourists, you can find out if they're coming back to hospitals in Maine or maybe they're going back to hospitals out of state, and that may suggest a different intervention is needed. If they are going to different hospitals in your state, it may be that you want to build some partnerships with those folks to figure out, by collaborating with those facilities, what happened to the patient.
Okay, so moving on to Section 6 of our report, we provide information on emergency department visits. Information on emergency department visits covers the total number of ED visits, percent of patients who visit the ED within 30 days of an inpatient admission, and the top 10 diagnosis categories. Please note that ED visits that result in an admission or observation are not included. So these are solely patients who presented to the ED and left the facility from the ED. The first chart in the ED visit section displays the total emergency department visits by quarter for the Medicare fee-for-service population. Please note that these numbers are based on patients being discharged from the ED. So as I said, patients that are being admitted or placed into an observation are not being counted as ED visits, and instead we just count those as an admission or observation. Second chart on ED visit section displays the percentage of patients who return to an ED within 30 days of a prior inpatient discharge. The denominator for this measure is the number of live discharges from an inpatient admission. the last section, we provide diagnosis-specific information that displays over the past year what were the top 10 ED visit diagnosis categories.
With these data, you can help broaden the definition of what it means to have a revisit to the hospital. The hospital readmission reduction program just looks at readmissions, but as all of us know, ED visits are also important from both a patient safety perspective and for cost reasons. Maybe there's a lot of opportunity in ED to make a difference in care transitions, and also to align with other hospital efforts to improve care.
Okay, so in addition to information that we provide on ED visits, we also provide information on observation stays. The information on observation stays covers the total number of observation stays, percent of patients within observation within 30 days of an inpatient admission, and the top 10 diagnosis categories. So please note, again, for observation stays this time, when it results in going in admission, it's not being included as an observation. The first chart on top is the observation section. This displays the total observation stays by quarter for the Medicare fee-for-service population. Please note that these numbers are based on patients being discharged from observation. Patients that are admitted from observation are counted as admission. The second chart on the bottom displays the percentage of patients who return to a hospital within 30 days of a prior inpatient discharge and are placed into observation. The denominator for this measure is the number of live discharges from an inpatient admission. In the last section on observations, we provide diagnosis-specific information that displays over the past year on what the top 10 observation diagnosis categories were.
Like ED visits, including observation stays in your readmission framework is really crucial to get a complete picture of unplanned utilization. And we actually recommend looking at observation rates in exactly the same way you look at readmissions. If you combine the two, it will give you a much more complete sense of when and why patients are coming back after discharge. Now, some of how you account for observation stays in your hospital will depend on whether most patients in observation status are intermingled on the floor with your admitted patients, or whether or not you have a specific holding area in the ED just for observation stays.
Okay, so we've reached the last section of our hospital report, where we provide readmission data on post-acute care. For post-acute care readmissions, we look at the discharge status on the hospital claim to see where the patient's discharge disposition was. For this section, we look at readmissions for patients that were discharged for home health, a skilled nursing facility, or other. Other being all the remaining codes except expired and left against medical advice. This is an example of one of the post-acute care readmission charts. This chart displays the readmission percentages for patients whose discharge status code is to a skilled nursing facility. For post-acute care readmission, the denominator is reflective of the same population. So the live discharges are, for this example, just those who were discharged to a skilled nursing facility. So if we look at this example, in quarter 4, 2016, this facility had 313 live discharges to a skilled nursing facility, and 71, or 22.7%, returned to a hospital within 30 days.
I love this section. It's always interesting to see how readmission rates differ depending on where the patient went after the hospital stay. It's important to keep in mind that folks going home without services will generally always have lower readmission rates than patients receiving home health or going to SNP. They're just a healthier population in general. But if you observe particularly high rates from either a skilled nursing facility or home health, you can then look further. You can see if there may be one or two facilities or agencies that are driving things. And then you can partner and explore with them why that might be so, and work with those folks. It's definitely a two-way street. So when you reach out to improve the communication process, this is the perfect time to find out from them and the rest of your community partners, what do they need that they're not getting when they accept one of your patients on transfer. That concludes the part where we walk you through each individual section, but I'd like to summarize what we've discussed. Before hospitals start looking at their data, before you open that email with a report, you kind of need to consider what the hospital's readmission goals are. Is it simply to bring the number of readmissions down across the board? Or is your hospital trying to target particular groups of patients or conditions? Is the main issue to avoid penalties? Maybe you're part of an ACO and you're looking to contribute shared savings. Or maybe you're quite ambitious and you want to transform the entire delivery system where you are. That would be nice, but it's not usually the case for most of us. And I think lastly, and this is on everyone's mind, what's the time frame and the budget you have to work on this? And then, to get to whatever the hospital's goals are, you need data. These hospital reports have this data in a really nice, convenient format. You'll also use your internal dashboard. And then the HIN and the PEPR reports can really help you build out that picture. Now, your leadership is going to want not just what's shown in the literature or in national studies, but what's going on in your hospital and your community. And that includes the voice of your patients and your community providers, which are not available in these reports. You'll choose areas to focus on and interventions based on your own data and your own goals. And then as you implement projects, like any QI activity you do, you're going to track your progress and revisit your interventions. And you're going to be looking at the overall readmission rate from the very first section, as well as some of that condition-specific information as you go through. And some of that patient demographic information, too, if you're targeting particular patient groups. So QIO and the HIN can help you take this beyond targeting the usual diagnoses. It can help hospitals develop interventions based on your own data, but also encourages collaboration across settings and inclusion of the patient perspective. And the QIO and the HIN can also assist with useful measurement approaches. I'd like to hand it back over to Maureen, who will take us through some of the question and answer.
Maureen, are you there? Did you press pound click?
Nope, I am. It just took a minute for it to tell me I was unmuted. So there actually were a couple of questions in the chat. The first one that I see asked, do the reports also show the number of repeated emergency department visits within 30 days?
Yeah, that's a very good question. For that, we're only looking at live discharges from the hospital. We only look to see if that patient went to an ED visit one time in a 30-day window. So we don't look at multiple visits, ED visits for that measure.
If they come back, if there's an intervening hospital stay and then they come back again and it all happens in a 30-day period, they would be included as a repeat visit after that subsequent index hospital stay. But
great, thank you.
It would be counted once.
Great. If you have other questions, I urge you to put them in chat. I had a chance while they were presenting to take a look at the people who are in attendance right now, and it's really nice to see so many of you here and so many friendly faces, even though I don't actually get to see your faces. I see your names, and I'm happy that I'm among good company here. I did sort of want to get the ball rolling and talk a little bit about how we have seen these reports be able to be used really quickly. Last week, the care transitions team here at the QIO went to visit a smaller hospital, and when we presented these reports and they looked at one of the initial pages, which was the number of days from discharge to readmission, 10% of all of their readmissions were occurring within the very first day. So that meant at a glance they could see that there wasn't really opportunity for them to get the folks settled to make a follow-up phone call and really take a look at what was driving these pretty quick turnaround readmissions. There happened to be a pharmacist at the table, and he had strong feelings that it was probably a medication issue, that people hadn't had a chance, couldn't afford to, or had the opportunity to pick up their medications. And the quality person at that hospital agreed that that was probably the case, since that is an ongoing issue at this particular facility. And it was also tended to be higher, the folks who were returning most quickly, were those who were referred to home health. So obviously, a problem was identified that home health hadn't even really had the opportunity to get into the home and help the patient. So right there was a very quick and easy way to see an area that really needed focus. And as we move on, I'm curious to hear what you all are experiencing. Do you think this could be helpful to you? Are there any other questions?
Maureen, it looks like someone in chat had asked about, on that same topic, if patients were readmitted, say, on day 15, how would you sort of draw conclusions from those data? How would you use that? So I think your sort of real-life example is very practical. You know, it would really depend on your particular hospital, but certainly readmissions coming in within just a few days after discharge would often indicate a medication issue, as you found at the hospital you were at. Sometimes folks coming in within, say, 15 days or 2 weeks. Not day 15 isn't a magic day in itself, but you'd really be looking at sort of that period leading up to that. If folks are coming in sort of in that second week after discharge, often that's a difficulty with follow-up or recognizing signs and symptoms of their condition worsening or not resolving. Maybe they were told that their condition or their symptoms would resolve after a week or so and they haven't, and not being sure who to contact for help, or maybe they contact their primary care physician and that physician doesn't know how to help them. Maybe they didn't know enough details about the hospitalization. And then later out, it's often not necessarily about what happened during the hospital stay at all. Or it could, in theory, represent folks who went to a skilled nursing facility, then are getting discharged home, say around day 21, and are not really prepared to manage at home, and now are coming back to the hospital. So those are different ways of thinking about different time points in those data. The only way to know for sure, unless your claims are very specific and point to a specific issue, is to say, okay, I'm going to put a little bit of resources, a little bit of time into interviewing patients in a particular time period that I'm particularly interested in. So at the hospital you mentioned, they might say, if people come in within 24 hours, we're going to make sure we get someone on the floor to talk to those patients and their families and find out what the issues are so we can really target that. So that's one way. Or a less time-intensive way would be to pull those charts and figure out, if you can, from the chart, what's going on.
Terrific. Thank you, Dr. Gardner. And my friend Trudy asked, can we get this data in Section 3 for previous quarters as well? And why is the total number of readmissions in Section 4 not the same as the number in Section 3? Blake, can you speak to that?
Sure. Maureen, would you mind passing the ball to me, and I'll flip back to some of those slides?
No, not at all. Hold on. Here you go.
So this is Section 3, which is we provide top 10 index admission diagnosis categories as well as the top 10 readmission diagnosis categories. And then the reason right now is, well, if you want to get in touch with Maureen, we could follow up with you on getting maybe previous quarters of data. We always selected one quarter because it gets to be a little bit much when you try to factor in more quarters to look at. The difference between Section 3 and Section 4 is here we're looking at, right now we're looking at the top 10 reasons why patients, or top 10 reasons for when patients left your hospital and were readmitted. And when we go a little bit further, we also give you the top 10 reasons on why they came back. Now in Section 4, we're simply taking those top 10 index admission diagnosis categories, and then we're providing you with all of the reasons why they came back for that specific category. So that's why the two won't match. The left side over here in the index admission diagnosis category should match Section 3 on the top 10 index admission diagnosis categories. the readmission diagnosis categories on the right here aren't going to match because they're all specific to that one admission diagnosis category. So for here, we're listing out all the reasons why patients come back. Oh, yeah.
Where you going?
Okay, so hopefully that answers your question.
Trudy, if you hit #6, you can come off mute and answer if that answers your question or ask a follow-up question. #6, Trudy. Maybe not. Maybe that answered all of her questions. Does anybody else have any questions? Pat, I know that you've had the report. Pat Novello, you've had the report for a little bit, and I know that when we presented there, people were really excited with the new enhancements. Have you been using it in a new way, or is there anything that you would like to add? #6 to unmute.
Hi, can you hear me?
I can. How are you?
I'm good. This has been great. Yes, we have a care transitions team. Our high readmissions from where they went after discharge is home care. So we are working with our home care facility and reaching out to the other facilities that visiting nurses that take care of our patients and seeing how we can improve patients being seen faster, because we are seeing in a few days the patients are coming back into the hospital. But this report has helped our facility tremendously, and we appreciate Maureen and her group coming down to talk to us and explain this whole report to us. It's been so beneficial to us, so I want to say thank you again for that.
Thank you, Pat.
Thanks.
*6 will put you back on if you want to be muted. Danielle posted a question in chat. We're curious, and you can just post in chat if hold on, I have to scroll up. We're curious to know from the webinar participants, can any of you envision using the new psych data for your care transitions interventions?
We hope, this is Rebekah Gardner, we hope that's going to be helpful data for you. We've certainly noticed in different hospitals here, and this isn't true for every hospital, but those hospitals likely know who they are, that they have really high readmission rates driven by folks with schizophrenia, major depressive disorder, and then certainly substance use disorders are really big, whether that's opiate use disorders or alcohol, and they certainly probably already know that from talking to their frontline staff and looking at their own dashboards, but this can be really helpful to see those numbers in black and white and really take a closer might get at those. That can be very reaffirming for people to see those diagnoses, because that's kind of what they're living every day.
Great. Thanks, Dr. Gardner. And Kristen Houghton said that, yes, she can envision that, and we're wondering, Kristen, if you could just talk about it a little bit, and you hit #6 to unmute. No?
I can say that in Rhode Island, looking at particularly with opioid use disorders and then sort of the sequelae of those, so maybe we don't see, the opioid use disorder listed as the #1 diagnosis, but we're seeing things like endocarditis and osteomyelitis, things that sort of flow from injection drug use. And that's really prompted the main hospital in the state, Rhode Island Hospital, to do a better job of trying to set up linkages to buprenorphine and other ways to treat opioid use disorders, instead of giving folks a phone number to call, to actually try to get that started while they're in the hospital. So that's kind of how they use some of these data here in Rhode Island.
Terrific. Thanks again, Dr. Gardner. Trudy did get the answer to her question, So thank you, and yes, Trudy, we will be providing a link to the slides following the presentation. I just want to give anybody, yes.
It's Morgan. I actually just put the link in chat to the event webpage, so the slides are located there.
Okay, terrific. Thank you. I want to put one more call out for anybody for questions or comments before we sign off. Like I said before, this is a great opportunity to have these experts here to sort of get to any nagging questions you've had or to sort of flesh out anything that you've been working on or would like to work on. And in order to do that, you have to hit #6 or just make a note in the chat box. I have a couple of friends on here I can't believe aren't answering questions, and I think you know who you are. Seeing none, and I can certainly be interrupted if there are any, I really once again want to thank everybody for being on here. Our goal really is to provide great service and to not only educate you on these slides, but support you in your quality improvement efforts and your care transitions. So please keep the lines of communication open. There's our contact information. Feel free to email any one of us at any time, and we can hook you up with whatever resources we need to hear from you. And I'm going to make one last plea. I'll ask whoever has the ball to do the last slide to complete our evaluation survey. We really do need the updated information for who we should be sending these reports to. We really do want to make these reports not only meaningful for you, but we want to make them actionable for you. So there's a section in there. I know that it takes a little bit of time, and we're grateful for the time that you've given us, but it can really help us provide you with better service. So to sort of wrap up, the link is on the chat to access the presentation following this one. And the link is there to complete our survey evaluation. And once again, I want to extend our, yes.
Before you end, it's Morgan. There's a few more things I wanted to mention, so don't forget to pass it over to me when you're done.
Okay, I will. Well, why don't I pass it over? Well, let me just one more time extend my gratitude for people for being on this call and to really extend great gratitude to both Blake and Dr. Gardner, who put not only a lot of time and effort into this presentation, but really always help us out on the care transitions team. They're there to not only help us, but to help our facilities, and we're so grateful to have them as a resource and to be able to offer them as a resource to folks that we work with. And with that, Morgan, I will pass it to you.
Thank you. So I know Maureen mentioned the evaluation, which you see the link on the screen too. But also, as you close out of the webinar, it will automatically pop up on your computer. So you can fill it out there or by clicking on the link on your screen. As I mentioned, I've created a web page where you will find the PowerPoint, and within the next few business days, we'll also upload a recording of today's presentation so that you can share that with anyone who may have missed it today, or if you want to go back and get a refresher. So again, make sure to fill out the evaluation, and thank you, Blake and Rebekah, for this great presentation. Hi, everyone.
Yes, and thank you, Sandy, for the great partnership. Thank you again, Sandy, for the great partnership.
Thank you.
The leader has disconnected. The conference will be terminated in 5 minutes.